Sinju, respond.
హలో సింజు, ఆడియో లేదా?
సార్ చెప్పండి చెప్పండి, ఏం చెప్పాలి?
ఆ అమ్మాయి ఏం చేస్తుంది? ఆ అమ్మాయి ఎందుకు రెస్పాండ్ అవ్వట్లేదు? పలిగిందా? సెకండ్ టైం కూడా ఇప్పిస్తున్నారని. ఓన్లీ వీడియో సార్, నో ఆడియో.
సింజు, హలో సింజు. వీడియో
Hello, Sinju, where is she?
Yes,
She's at
sir.
home
Hello,
or,
can you hear me?
yes
Hello.
yes.
Yeah. Any problem with audio, Sinju?
No. Are you able to hear me clearly?
Still little bit loud.
Louder you want.
అంటే your laptop, earphones.
No, stop that video and go to the first screen first. Go to the first screen.
No, sir, is this voice clear or not, sir?
Yeah, increase the volume.
Keep it maximum.
Make it 100%. Enough.
Now speak once.
Hello. Yes, sir. Am I audible enough?
That is enough.
Sir? Okay.
Yeah. Go to the first screen.
Sorry.
Go to the initial slide.
From the beginning?
Okay. You want to start from there?
Yes, sir.
Okay.
Why from the beginning?
Last time I had already presented till
Okay.
here.
Okay.
So this was the video which was left. So I'll start from here, sir.
Okay.
Yeah. Start from here and need not to explain everything. Just to show the video and go to the pathology.
Yes. Sir, actually, I'm giving a quick recap of the anatomy, CT anatomy.
Okay.
So in this video, this is just. Can I start now?
Wait. Only 7 members are there.
Okay.
Rajesh sir, good morning. Hello, Rajesh sir. Rajesh sir.
Sir.
Good morning. Good morning. Signal బాగానే ఉందా?
Good morning, sir.
సిగ్నల్ బాగానే ఉందా?
మధ్యలో వస్తుంది.
ఓకే సార్, అదే కొంచెం చూస్తా ఉండండి సార్.
ఇప్పుడు లేదు.
ఓకే సార్.
There's one net call. Wait. You're leaving? ठीक है.
Sister, capsule.
Madam? Hello? Madam?
డేవిడ్ గుడ్ మార్నింగ్.
Good morning, madam. Start చేద్దామా?
స్టార్ట్ చేద్దాం డేవిడ్, మళ్ళీ లేట్ అయిపోద్ది.
అందుకని. Yeah.
అదే సేమ్ డాక్టర్ సింజు అండ్ డాక్టర్ రాజేష్ విల్ బి ద మోడరేటర్. విల్ కంటిన్యూ.
Okay, madam. Okay.
ఓకే.
Good morning, all. Today we are continuing with the approach to CT brain. As we have done most of anatomy part with Dr. Sinju, moderated by Dr. Rajesh Posarla. Now she is going to continue the rest of the images. Thank you all. I request Dr. Sinju to start the presentation.
Yes, sir. So, good morning, everyone. So today I'm going to start with the CT anatomy. This is just a normal CT anatomy. I'm going to just give a quick recap of the structures which we had not seen last time. So, starting from here, this is the false cerebri. It's nothing but the dural invagination into the cerebral hemisphere. We have this anteriorly and posteriorly, and what we are seeing over here is the marginal sulcus. It's called as a mustache sign, and just anterior to that, what you find is a central sulcus. It's somewhat like it somewhat resembles that of a reverse omega sign, and anterior to this lies the motor cortex, posteriorly lies the sensory cortex. So this is an important demarcation which we have to note. Then as it proceeds further, what you get is this is the portion which is called as centrum semiovale. It is very well above all the lateral ventricles.
సింజు can't hear.
Oh. Am I not audible, ma'am?
Audible,
Hello?
Sinju. You are
Yes,
audible.
I'm audible. Yes.
Yeah. You talk loudly little bit.
Okay. Yes. So what we are seeing over here is the lateral ventricles, the body of the lateral ventricle, and just adjacent to that lies our corona radiata. That's an important structure which we have to note down. And as we proceed further, what you're seeing is the choroid plexus, which is in the ependymal lining of the ventricles. It has somewhat got calcified, and here as it moves further, the structure which the hyperdense structure which we are noting over here is the pineal gland. And this fissure which is coming over here is a Sylvian fissure. This again marks an important landmark because it's this fissure which divides the hemisphere superiorly into frontal lobe and parietal lobe, and inferiorly into temporal lobe. And the structures which you are seeing over here is the anterior horn of the lateral ventricle, and which is separated in the midline by the septum pellucidum, which is here. And this is the third ventricle. And what we are seeing over here are the posterior horns of the lateral ventricle. So as it's expanding further, this third ventricle, we can make out the cerebellar vermis, which is coming over here. And again, this is forming the cistern which is lying over here is the quadrigeminal cistern, and which is extending laterally into either side into ambient cistern. And as we move further, we can make out the suprastillar cistern which is coming up over here, and it forms an important landmark in the circle of Willis. This is where the circle of Willis sits, and again, here what we are seeing is the cerebellar vermis, and either side we see the cerebellar hemisphere. This suprastillar cistern has become more prominent over this portion. Here what we are seeing is the this portion is the midbrain. It's somewhat Mickey Mouse shape and structure, and either side it is extending laterally into cerebral peduncle. This is the temporal horn of the lateral ventricle, and as we move further, what we are seeing over here is the dorsal celli where the pituitary gland sits, and the fourth ventricle has become more prominent in this region. And we have this prepontine system which has come up over here, and the hypertense structure which we are seeing over this area is the basilar artery. And again, other structures which we are supposed to see are the various venous sinuses. So the transverse venous sinus would be somewhat over the posterolaterally, somewhat it would lie over this area, and it would okay. This would continue as sigmoid sinus here in the sigmoid sinus, and further it would drain into the jugular venous sinuses, which comes up over here. This portion. Okay. Now moving on to the next slide. So I'm going to give a brief introduction to whatever we had seen last time. So the hyperdense lesions, as per the radiological density, would have a quantitative measurement around plus 80 Housefield units. That is for clotted blood. And as we know, the gray matter, which appears white on the CT scan brain, has a quantitative measurement of plus 40 radiological density, and white matter around plus 25. So white matter actually appears grayish in color, and gray matter appears whitish in color. And the CSF has a density lesser than all of these, and it is closer to water density, which is 0. But this CSF density is allotted plus 15 Housefield units. Moving further, grossly, as a non-radiologist, what we are supposed to not miss out on a CT scan is this mass effect. So if there is a mass effect, how to make out a mass effect? Sulcal effacement would be there. As you can make out here, there are the various sulci and the gyri, which can be easily made out on this right side of the hemisphere. And the left side, we are not able to make out any of the sulci and the gyri, which means there is gross mass effect over this portion that is on the left side of the hemisphere. So other parameter which we are supposed to see is whether the mass, how much is the mass effect, how much is the midline shift. So we join two lines. This is the anterior portion of the cerebral valve and the posterior portion of the cerebral valve. So the line joining either of the two ends, and then the septum pellucidum. Here we have the septum pellucidum. From that line, we'll draw a perpendicular to this line, and that gives a linear measurement of the midline shift, how much it is. Now going on further, any kind of herniation is also not supposed to be missed out. So subfalcine herniation. So what we get is a falx cerebrae over here. It's nothing but a dural invagination into the cerebral hemispheres. So any brain matter which is lying beneath this free end of the falx cerebrae, if that is causing any kind of herniation, or if it is herniating out beneath this free edge of the cerebral falx, it is called as subfalcine herniation. So the complication which can be seen along with this would be ACA infarct, because the ACA, that is the anterior cerebral artery, have a course running along this side, and which is the reason why ACA infarct is one of the common complications associated with that. And similarly, foramen of Monro. So as we know, the lateral ventricles, that anterior arm of the lateral ventricles, that would drain into the third ventricle via foramen of Monro, and foramen of Monro, if gets compressed due to the subfalcine herniation, you would find hydrocephalus of the ventricles which are proximal to it. So again, proceeding ahead, we'll see transtentorial herniation. This can be of two types: ascending type and the descending type herniation. So the ascending type, so transtentorial, as the name itself suggests, there is this cerebellum, tentorium cerebelli, which is nothing but the dural separation, which is dividing the whole of brain matter into supratentorial contents, which contains frontal lobe, parietal lobe, temporal lobe, and occipital lobe superiorly, and inferiorly contains just the cerebellum, both the cerebellar hemispheres. So the contents are divided in by this uh, trans by the cerebellum tentorium. And if there is any herniation which is happening from the infratentorial contents, like infratentorially any cerebellum, if it is ascending up while through this tentorium cerebelli, we get ascending transtentorial herniation. So how to make out an ascending transtentorial herniation is we look out for the quadrigeminal system. If it is not visible, if it is not visible, as you cannot see this quadrigeminal system which is supposed to come over this portion, then you call it as ascending transtentorial herniation. Again, descending transtentorial herniation is when you find the when you're not able to make out the suprastillar system on either side. So here, as we can see, the structure of the suprastillar system is basically a star-shaped structure which can be easily made out on a CT scan. Here, it is not visible at all. It is because the uncus of the temporal lobe has permeated into the suprastillar system, and which is causing compression effect, and which is the reason why we cannot make out the suprastillar system over here. But when there is bilateral uncal herniation, which is the case with this, the suprastillar system is absolutely getting effaced, which is the reason why you are not able to see any of the portions. So with bilateral uncal herniation, the complications are many, especially what you can find is there is if the uncus is herniating to the opposite side, you can see the compression effect would cause ischemic effect, and in which case you would find contralateral weakness on the other side, contralateral weakness, and ipsilateral damage would be there. But if the damage is too much, then even ipsilateral weakness can also be seen, and contralateral damage can also be seen, and in which case there is loss of localizing sign, and it is called as Kernohan's notch. And the midbrain, if it is getting affected, midbrain hemorrhage would be seen, which is a sign called as durate hemorrhage or durate hemorrhage. The last but not the least and very important thing is tonsillar herniation. So the tonsillar herniation, as such, what in a normal structure which you see is this is the foramen magnum, and in a normal CT scan of brain, you would be able to make out the cerebellar tonsils over this portion, and free space which is lined by CSF over here, and our medulla oblongata would continue as spinal cord in this portion. So at least we can make out a hypodense area, which is nothing but our CSF in and around this portion, in and around the structures which I've described already, such as cerebellar tonsils, around the spinal canal. But what we are missing out here is there is no hypodense lesion. There is no CSF inside this. So that means this has got completely effaced. There is absolute fullness of the foramen magnum, and if that is present, then what you suspect is tonsillar herniation. So in such cases, so tonsillar herniation, definitely it would cause hydrocephalus of all the proximal ventricles, which is lying above this. Plus, what you can see is a respiratory and cardiovascular complications. There would be imminent respiratory and cardiovascular collapse. Okay, so moving ahead, the kind of bleed which we usually see on a CT scan of a CT scan image of a trauma patient. So here we have a image on the right, on the left side. Here we have an image of extradural hemorrhage. So how do we make out an extradural hemorrhage in a CT scan? Usually you see this lentiform kind of hypertense lesion, which is seen in the left side of the frontal lobe, and this is lentiform in structure. So this structure is basically not crossing the suture lines. So that is one of the things. And the shape is biconvex in shape. And what other things you can make out is the mass effect would be, again, it would be depending upon the size of the lesion. And in with this case, you can make out there are circle effacement and effacement of the ventricles over this side, which is the reason why there is mass effect in this case. So EDH usually on a clinical basis, you would find this thing associated with a trauma patient. There would be absolute loss of consciousness, followed by a regain of consciousness, but there won't be any recall of events, whatever happened, and that's called as a lucid interval. So in EDH, you would always find a lucid interval. And the other important factor is the bleed is happening from the middle meningeal arteries, which is the reason why this bleed can happen in a very short period of time, and there would be progressive loss of consciousness, and which would require immediate surgical intervention. So this patient should immediately go for surgical evacuation and craniotomy. On the right hand side of the screen, on the right hand side of the screen, what we are finding over here is a subdural hemorrhage. So in subdural hemorrhage, how we are supposed to make out is the structure which you are seeing over here, the hypertense lesion. It's a crescentric shape or a moon shape, and it is lying over the lying in close proximity with the margins of the cerebral hemisphere, which is the case here, and it is causing it is not crossing the midline, and moreover there is no it is not crossing the midline, and even it is crossing all the suture lines. So in EDH, it is not crossing the suture lines. Why? Because there is periosteal attachments to the suture line. It is the reason why it is limited to the sutures. But here it is not like that, because it's lying way inside, and it is lying in close association with the cerebral hemispheres. So again, what you can make out on this side is mass effect. There is effacement of the ventricles on the same side with sulcal effacement. And in SDH, it could be traumatic, non-traumatic, as in young children also you would find. And SDH usually it arises from the dural venous sinuses, which is the reason this has a gradual progression, and there won't be any lucid interval. And patient might present in confused state, and we have to just monitor the level of consciousness. And just in case it deteriorates, that is the time when you require any surgical intervention, or in which case we employ a burr hole and evacuation of the blood. Now, moving ahead, here on the left side of the screen, what we are finding is the hypertense lesions all along the suprastillar cistern, and this is the portion where the circle of Willis lies. So here, what we are seeing is the bleed is in the subarachnoid space, and any aneurysmal bleed, any kind of trauma, or any mycotic aneurysm which is ruptured, any cerebral amyloid angiopathy, all these things would result into subarachnoid hemorrhage, which we are able to find out over here. Again, in the right side of the screen, what we are able to see is a hypertense lesion, which is an intraparenchymal bleed. And this bleed is one thing, once we make out the bleed, we are supposed to know what is the location. So the location here, it is the frontotemporal region, and associated with the areas of hypodensity all around, which is nothing but the perilesional edema, and it is causing effacement of the sulci on the same side, and also it is pushing the ventricles to the opposite side, and so you can make out a mild midline shift. And here what you're seeing is the intraventricular bleed, which is seen in the posterior horn of the lateral ventricle. So again, blood over time has a different density. An acutely clotted blood, as I mentioned before, has a density closer to plus 80 Housefield units, and as it goes over, as it progresses, it has a lesser density compared to acutely clotted blood, and a chronic bleed would have a density which is closer to CSF, that is around plus 15 Housefield units. But a hyperacute blood, again, it would not have a much density. It would be hypodense compared to an acutely clotted blood, and on a scale, this would be lying closer towards 0. So here what you see is the lesion, hypodense lesion in a background of hypertense lesion. This is an EDH basically, and what you're seeing is an hypertense lesion, and this is nothing but indicative of hyperacute bleed. This is otherwise called as a swirl sign. As I mentioned before, acute and chronic SDH. So here what you're seeing is along the calvarium or the hypodense lesion, which is concentric in shape and is lying over the all along the margins of the cerebral hemisphere, is a lesion which is having a density closer to that of the CSF, right? So this is a chronic SDH. So this chronic SDH, again, if there is a bleed which is happening in this chronic SDH, this would appear as hyperdense on the CT scan, and this it would be labeled as acute and chronic SDH. So moving ahead, so here is a video which is showing. So again, as I mentioned before, you are supposed to look out for the fullness of the foramen magnum. We'll go one by one. Again, pre-pontine space, if it is free or not, the CSF we can make out or not. Any again, here the structures, normal structures, the normal anatomy one was able to make out, and what you're finding over here is the intrahemispheric fissure, and there is hypodense lesion lying along the intrahemispheric fissure, which is associated with a hypodense lesion all around. It is probably a perilesional edema or say infarct, and this is causing herniation, so falcian herniation again, and so this is an interhemispheric fissure. Any interhemispheric fissure you're supposed to look out. You're supposed to suspect as subarachnoid lesion. So we'll do a CT angio to confirm this case. So on eventual evaluation, it was found to have anterior communicating artery aneurysm. Now coming to this case. So here we can make out there is this hyperdense lesion which is coming up in the temporal lobe near the occipital horn of the lateral ventricle, and this is along the right side. So this lesion is expanding. It's probably an intraparenchymal bleed which is expanding into the parietal lobe. So temporoparietal lobe is getting affected, and again note down this hypodense lesion which is lying along the calvarium of the skull, and this is having a concentric in shape. So this is somewhat indicative of a chronic SDH, and here you can make out there is hypodense lesion, again a hypodense lesion which is moreover indicative of a chronic infarct, which I'll be covering up in the slides ahead. So again, there is also effacement on the right side of the hemisphere, causing mild midline shift.
Stop.
Okay, so moving ahead, so again we had a case of 65-year-old male who was chronic hypertensive, presented to us with chronic headache and photophobia, with nausea, vomiting, and neck stiffness, and there was progressive weakness over the left side, and there was loss of consciousness eventually, and that one can make out all these hyperdense lesions. So hyperdense lesion, which is seen in the anterior horn of the right ventricle over this portion, and this is the portion which is corresponding to our important gray matter structures, that is the thalamus, the caudate nucleus over here, which is adjacent to the ventricle, and the lentiform structure, which is the globus pallidus medially, and laterally what you find is putamen. And here in the posterior horn of the lateral ventricles, you can make out the hyperdense lesion again. So it's all inside the ventricles, plus the intraparenchymal bleed is there. So this is nothing but a case of intraventricular bleed, which is lying in the right horn of the right anterior horn of the lateral ventricle, the right posterior horn of the lateral ventricle, and occupying most of the thalamic and important gray matter gray white matter structures, which is sinus region. So here again, the body of lateral ventricle, you can see a huge bleed. So moving ahead, huh. So AV malformation. So how do we make out an AV malformation? Here you can see there are tortuous dilated vessels which are seen in the right side of the parieto-occipital region. It is causing effacement of the posterior on the lateral ventricle. And here in this portion, you can make out the transverse sinus. So there is some communication which is happening between this AV arteriovenous malformation with the mm, with the transverse sinus. So what do you find? The patient here came with a patient was a 65-year-old male who presented with a history of seizure and headache. So what you find over here is like the basic pathology behind this is that there is this vascular endothelial growth factor which is undergoing mutatic changes and which is causing dilatation and vascular malformation. And there is eventual involvement of a cytokine-mediated vascular remodeling which is happening. And this ultimately results into arteriovenous malformation. So the next slide, you would be able to make out there is this needles, uh, there's this needles, there is a feeding artery and a draining vein, all of which is communicating with the transverse venous sinus. So this is our venous sinus. This is done on a CT angio. We can make out the appearance resembles closely to that of a bag of worms, and which is the reason I've put up this figure of CT angio here. So moving ahead, we can talk about the basic concepts of stroke. So what you're not supposed to miss out on a stroke is in the initial stages, that is in acute stages, one would not be able to make out a gross change on a CT scan of brain. And what is initially seen is just a hypertense lesion, which is so always compare the density of a vessel uh, with the with any with a on a stroke window scale. So you can make out that this is where the usually the middle cerebral artery would run its course along the sylvian fissure. So you have to locate this in a running CT scan video and then look out its density, compare it if it is hyperdense compared to the adjacent structures. This would be closer to the density of the skull brain, but not having much density closer to that. So you'll have to adjust the scale and see if it is a hyperdense lesion. Then definitely hyperdense vessel is indicative of a stroke, impending stroke. And here again, we make out gray white matter differentiation. So what you can see over this portion is this white, the grayish matter, which is whitish in appearance, and the inside matter is whitish matter, which is grayish in appearance. So you can run along the course of the sulci all over. And when you come over here in this portion, you are not able to make out this. This is normally what is witnessed, and this here, what you see is the gray white matter differentiation, which is not even properly seen. And this is because what happens is in a stroke, the vessel is occluded, so the tissue which is distal to that is not receiving the blood supply. So the distalmost tissue which is getting affected, the uh, cortical one, which is having a whitish in density, right? So that the cells in that region would undergo dysregulation. The sodium potassium ATPase channel would not be working properly, and ATPs would not be ATP would not be made properly, and in which case it would result into cytotoxic edema. There would be accumulation of water in there in the gray matter, and this would lose its density. It would lose its density and would approach a density closer to that of the white matter. So the gray white matter differentiation is not made out, and this is the reason why you're not able to see a proper gray white matter junction over here. And so this is what is the second sign which we are supposed to look out for. So evolution of stroke on acute in acute stage, again, here is the insular cortex. This is the portion. Again, insular cortex is the portion which, even though lies most distally, but the arterial supply in here would receive somewhat the arterial supply in here would be most distant, and which is the reason why you would find this insular cortex to be affected in the initial stage. So again, this is the first stage, which is the most sensitive area, and it is to be looked out for in any CT scan of the brain where you're suspecting stroke. So this is the area which where you would be able to find out that there is no gray white matter differentiation, so it would start losing it. This so in 2 days it would evolve completely, and there would be a hypotense lesion which you would be able to find in the right side of the left side of the hemisphere, so which is causing circle effacement and consequent effacement of the corresponding ventricles on the same side. And the lesion here is much um, much much more significant when compared to this stage. And over a period of 5 days, if it is not controlled in the initial stages, it would evolve into midline shift, which you are able to make out here as in the line joining the two anterior and posterior ends of the cerebral pulse, and we are drawing a line perpendicular to the septum pellucidum here. You would be able to make out a clear-cut midline shift is present. And again, on a chronic stage, you would find that the infarct has lost its density, and it has become somewhat closer to the density of the CSF. And this is the portion where this is the stage where you would find negative mass effect. So all here you were finding a positive mass effect. This is the portion you would find a negative mass effect, and the ipsilateral ventricles has undergone hydrocephalus rather in a chronic stage of infarct. So coming to various kinds of infarct. So based upon the territories which any artery would supply. So basically we are going to deal with middle cerebral artery, posterior cerebral artery, and anterior cerebral artery. So we have to be very well versed with the supply of the cerebral supply in each of these. So in an MCA, what you find is the supralateral portion of the hemisphere which is getting perfused with the middle cerebral artery. So it spares the medial portion, as you can find over here. The medial portion is spared. Medial portion of the frontal brain is spared. Most of the it is affecting most of the supralateral portion, which consists of the inferior lobe, inferior parietal lobe, and most of the frontal lobe, just excluding the medial portion of the frontal lobe and superior portions of the temporal lobe. So as you can see here is this is our suprastillar cistern. It is a star-shaped structure, and here you can see a lateral branch of middle cerebral artery which is going laterally, and this is somewhat hyperdense compared to the other structures, right? So this is where you can make out a hyperdense MCA vessel, and this is indicative of middle cerebral artery infarct. So in middle cerebral artery infarct, again, clinically, how do you find it? How do you find it that you would find that there is more involvement of the upper extremity and the upper extremity and the upper extremity and the face, that is motor and sensory infarct would be there. Motor and sensory infarct would be there, which is particularly seen affecting the upper extremity and the face when compared to the lower extremity. And if it is involving the dominant hemisphere, you would find aphasia. And if it is involving the non-dominant hemisphere, hemi-neglect would be seen. So coming to ACA infarct, you would find, as you can easily make out, there is a hypotense lesion along the medial portion of the frontal lobe, and also involving the superior parietal portion. So this is the portion where you can make out the two lobes. So here, this is the superior parietal portion, and here what you find is the medial portion of the frontal lobe. So ACA, as the name itself suggests, it runs along medially, and goes anteriorly. Here, as we know, the orientation of our as you can find out the orientation of the the bodily orientation, you would find the legs would lie in the interhemispheric fissure, and that is the reason why the lower extremity motor deficit or sensory deficit would be much more prominent when compared to upper extremity or facial lesions. So again, an important point of differentiation is that there is there is urinary incontinence, which you can see clinically in such patients who are affected with ACA infarct. So going ahead, as the name itself suggests, posterior cerebral artery, it would supply the occipital lobe, posterior portion of the occipital lobe, and some posterior portions of the parietal lobe, and some posterior portions of the inferior temporal lobe. So here, what you can make out is the hypotense lesion, which is seen in the course of posterior cerebral artery, and here is the occipital lobe. This is the left occipital lobe which is getting affected, and on a clinical basis, what you might see is the homonymous hemianopia and motor deficit, limb apraxia, and all. Moreover, the signs will be showing 4Ds: dysphagia, dysarthria, dysphonia, hoarseness of voice, and diplopia. So we'll move ahead to pica infarct, that is posterior inferior cerebellar artery. So here you can see the cerebellum is getting affected. The cerebellar hemisphere, which is the left cerebellar hemisphere, is getting affected. So it supplies, as the name itself suggests, it supplies the posterior inferior portion of the cerebellum. And here what you find is the pons, and so the lateral portion of the pons, again, that is getting affected. And sometimes you would find the sometimes this would be extending further down, and the vermis is also getting affected at times. So in ICA, that is anterior inferior cerebellar artery infarct, here what you would be able to make out is as the name itself suggests, anterior inferior portion of the cerebellum is which is getting affected, and here the cerebellar peduncle, sorry, not cerebellum, the lateral portions of the pons is getting affected. And when you move ahead in the superior cerebellar artery, here is where the the superior portion of the cerebellar hemisphere and the vermis, which is getting affected, and sometimes the in association, the upper portion of the midbrain is also seen. So in pica infarct, you can even make out this lateral medullary syndrome or Wallenberg syndrome. So again, the 4D, that is dysarthria, dysphagia, dysphonia. Along with that, you would be able to see a Horner syndrome, and also hemifacial spasm. That is because of the involvement of the trigeminal nerve, you would find pain on the same side and the hemisensory loss on the opposite side. So that is something which I missed out on pica infarct. So in watershed infarct, so watershed infarct or border zone infarct or hemodynamic infarct is nothing but you find such cases in patients who are already hemodynamically compromised and who already had a stenosis involving the major vessels. So in such cases, like major vessels, especially the internal carotid artery or the branches of it, anterior cerebral artery, MCA. So in a background of hemodynamic instability or hypotension, if there is a superimposed pre-existent stenosis of the major vessels, you would find the vessels which are not receiving any collateral supply, the region of the cortex which is not cortex or the brain matter which is not receiving any collateral supply would undergo infarct, which is called as a watershed infarct. Like in this case, ACMC infarct territory, you would be able to make out that this is the portion, the frontal cortex. In the anterior horn of the frontal cortex, you are finding the motor portion, the small strip of motor cortex is getting affected, and this is because of the hemodynamic instability, and which would improve if the blood pressure is kept care of. And over over here, what you're finding is an MCPCA territory. So usually this is not MCPCA territory infarct, but I'm not MCPCA watershed infarct. I've just kept an example of this. So again, a motor strip in the anterior portion you can make out involving the left frontal cortex. Usually, this is usually seen in the in close approximation with the anterior horn of the lateral ventricle. You would find any hypotense lesion involving the cortex, and that is the portion where you would find which is devoid of any collaterals from AC or MCA, and which is the reason why this would undergo hemodynamic infarct. So this was a very rare case which we had seen in our ICU. So there is a patient, a 60-year male patient with chronic hypertensive who presented to us with gait imbalance and hemifacial spasm, and on evaluation was found to have trigeminal neuralgia. So on a CT scan here, especially you can make out this is the foramen magnum, and here you would see the medulla oblongata extending into spinal canal, and this hypertense lesion, which you are able to make out, is nothing but the basilar artery. So vertebral basilar artery here, vertebral basilar artery is undergoing dilatation and tortuous course, which is causing compression lesions on the adjacent midbrain and pons over here, and which is the reason why this patient is and this is the portion where you would find the trigeminal nerves also running along, and that is getting compressed, and that is the reason why you get trigeminal neuralgia in such cases. It was a very rare case which we could find. So coming to diffuse axonal injury, usually a CT scan is not diagnostic of a diffuse axonal injury, but any patient who presents with history of loss of consciousness at this in a very heavy motor vehicular accident, sustained severe contusional injury to the brain, and there was visible external injury, and on the spot loss of consciousness, and when was brought over here, he persisted into a state of irreversible coma. So in such cases, if you're able to see on this CT scan, there are multiple hypotense lesions which you are able to make out, which is associated with a lesion of hypodensity around it, and which is nothing but our perilesional edema, which we can make out. But on a gross basis, you won't be able to see much of findings. But that is the point when you're supposed to suspect a diffuse axonal injury. So here was a case of a 30-year-old male who presented to us absolutely unconscious and persisted into comatose state. So basically what involves is what is the mechanism of injury in such cases is a shearing force. So because of the rotational deceleration acceleration force at the gray white matter junction, you would find that they would because of the difference in the specific gravity of the gray white matter junction, this would undergo severe disruption, and there would be minute kind of bleed, which is either ranging from millimeters to centimeters. You cannot even make out grossly, and then there would be perilesional edema or hypertense lesion, which you would be able to see on a CT scan axial section. But always suspect for diffuse axonal injury in such case, and go ahead with T-weighted MRI. Now, going ahead to intracranial SOLs, again, any stroke would mimic. So intracranial SOL would mimic all the symptoms of stroke. So one has to be very vigilant about vigilant about the findings which you get with a space occupying lesion, and should be able to differentiate. So that is the reason why I have put up these two slides, not covering much, just the intraaxial and extraaxial lesions. So intraaxial lesions, what you would find is basically, if it is primary, it would be primary. If it is a primary, the most common lesion which you get is a glioma. If it is multiple, multiple lesions are found, then basically it has to be metastatic. The primary lesion would be somewhat singular in structure. And extraaxial lesions, which is arising from the meninges, as the name itself suggests. So that's why the most commonest lesion I'm going to mention, that is the meningioma, and just the basic findings. So intraaxial tumors, here you can make out the hypodensity. So basically, any space occupying lesion would have a difference in density. It would be hypodense, hyperdense. So mixed density lesion you would find. So here you can see a low dense area, and there won't be any pattern of what do you say? Any specific pattern. It would be irregular in shape, or it would be occupying. It won't be corresponding to any of the infarct territories. So it would be all mixed up. And if at all any infarct is happening, it would be because of the pressure lesions or the vasospasms, which would be causing infarct. So here you can see a area of low density, which is causing sulcal effacement on the same side uh, with effacement of the ventricles on the same side. So here the lesion which you are finding is basically a glioma, and post contrast what you are able to see is a ring enhancing lesion. So the centrally the hypodense lesion which you can make out over this portion is nothing but the necrosis, and in all along the peripheries the hypodense lesion is indicative of the perilesional edema. So one thing in a space of occupying lesion is mass effect. There will be obvious mass effect. Secondly, the lesion is having difference in density. It would be either hypodense or hyperdense, mixed density, and on post contrast, you will be able to make out a ring enhancement sign. So this is a glioma which I've mentioned over here, and this more extreme on the right side, you would find the multiple hypodense lesion which is seen on either side of the brain. Here, basically, it was a case of CA lung, and this is what we are getting as cerebral metastasis. So multiple lesions are seen on the which is scattered over all over the hemisphere, and this is nothing but a cerebral metastasis, and high suspicion has to be kept for underlying underlying primary tumors. So moving ahead to extraaxial tumors, so you can find this is a benign tumor which is arising from the meninges. It is more, it actually has this gradual course. The patients would present with a chronic headache history, which is postural, more of a postural, and then might even present with seizures. So here, what you can see is this lesion is arising from the meninges, and this has central calcification, which you can make out over here, the small punctate lesions, and this is having a rounded convexity, and moreover, it is tapering into a tail, which is called as a dural tail, a dural sign. So this is arising from the meninges, and it is still attached to the surface of the dura, and which is the reason why you are able to see a dural tail. This is otherwise called as dural sign. So this is the indicative of meningioma. What you can find over here is the perilesional edema, and again, after contrast, you would be able to find a ring enhancement lesion. So not just intraaxial, extraaxial tumors or bleed. We are also supposed to look out at the skull calvarium grossly. At the skull calvarium, many trauma patient which comes into ER or ICU will just have to look out and rule out if there is any gross fracture of the skull, which is causing contusional injury of the brain matter, or causing any bleed inside, or causing any impending mass effect. So what are the things which you are supposed to look out for? In a skull fracture, when you are describing about skull fracture, we have to look at the base of skull. If the base of skull is intact or not, this is the portion where you look at the base of skull. So different axial sections you will find it differently, and the skull calvarium on a gross basis. So here is the structure. basically you look at all the major bones. So here we have the frontal bone, the parietal bone, the temporal bone, and the zygomatic process, sphenoidal bone. This medially we have the ethmoid bone, and here is your zygomatic bone, which has this temporal process over here. This is our maxillary bone, and even the mandibular fracture. Mandibles also, if there is any mandibular fracture or not, that also has to be ruled out. So, in how do you describe a fracture? It could be open or closed, based upon whether it is communicating with the wound or not, and it can be linear or comminuted, or displaced or undisplaced, or causing depressed fracture. All these things we have to make out on a CT scan of the brain. So here is a video, CT video of the a traumatic patient which we had in our ICU. So here you can see this is our so the basic structures are here. You would find the ethmoid sinus. This is our retromaxillary sinus. So this is the eyeball. What you're finding over is here is the sphenoid bone which is extending. This is the lateral. Sorry, this is the lateral portion of the orbite. The lateral or portion of the orbite, which is having undisplaced linear fracture. When you're proceeding ahead, you would find there is retromaxillary sinus hyperdensity, which is nothing but hemosinus. That is, blood is there in the sinus. Again, when you move, ahead, here what you can find is the fracture, which is involving the sphenoid sinus, and and here you can make out the linear undisplaced fracture of the temporal bone and frontal bone and frontal sinus, and there is hemosinus, that is, blood is there inside the frontal sinus. Again, here again you would find this is moreover in the frontal cortex, frontal bone. Here again there is this undisplaced fracture. So here the windowing has been done differently, if you have noticed. So the brain matter is comparatively appearing darker to the skull bone, and they have made it purposely in order to understand the structure which is under study in a better way. So here, when you are particularly concerned about all the skull bones, we have to approximate the windowing or keep a level closer to that of the skull bone, so that this appears much more darker much more brighter in density, and the remaining brain matter would appear, the remaining brain matter would appear darker in color. Okay, so let's move ahead. Yes. Yes, sir.
Yeah, you can try to wrap it up and leave time for discussion.
Yes, sir. This is the last slide. So this is okay. Not just we should not be just concerned about bones. We have to look out the sinuses. So in any so mucormycosis was a common entity which we had witnessed during our COVID era. So that's the reason why I have included the slide. So here you can find. So here you can find this portion. This is the retromaxillary sinus. Here, the hyperdensity which you can make out is nothing but there is soft tissue density which you can see, and in the ethmoid sinus as well you can make out. So the soft tissue density which is involving both the ethmoid and the maxillary sinus, which is extending into the extraconal space of the left orbit, is indicative of a mucormycosis, which you can find it in an immunocompromised diabetic patient or patients who've been put on steroids or was having any underlying immunocompromised state, or because of which they have developed this mucormycosis. So something interesting is that that's the reason why I have put this slide. So my point is, like, it's not just black and white, it's a million shades of gray, and we have to adjust the windows appropriately to make the proper interpretation. So I'm going to end up here. Thank you.
Thank you, Shinju, for a nice presentation. I
Thank you,
request
sir.
Dr. Rajesh to make a comment on this final, just finishing 2 or 3 minutes. Hello?
Sir, yes, sir. Am I audible?
Yes,
So,
sir.
you have covered well all the pathologies in a very short time. So, the basic idea is to understand herniations as critical care physician. Herniations are something and infarctions are which you see in your day-to-day practice. So it is important to understand these herniations because the patient's condition will change very quickly if it is not recognized at the proper time and in the proper setting, especially the descending transtentorial and the transtonsial herniations. These are the situations where we hardly get any time and it needs to be intervened early. So in the herniations, you have said everything. What you didn't mention is when the brain parenchyma herniates, there is infarction of the adjacent the vessel. It herniates the vessels adjacent to it also herniates. Like in the subfalcal herniation, it is the cingulate gyrus which herniates under the Farcs. The cingulate gyrus goes under the Farcs to the opposite side. So it also takes the anterior cerebral artery along with it. When it compresses the anterior cerebral artery along with it, you will see associated infarctions of the cingulate gyrus of the ACA territory. So in the case of a subfalcine herniation, when you see ACA infarctions, so it is secondary to the subfalcine herniation rather than secondary pathology. Also, when there is descending transtentorial herniation and all, you also have to understand that there can be like in a transhalar herniation, there will be MCA infarction. In a transtentorial herniation, there will be associated infarctions of the posterior cerebral artery also. It can happen. So all these associated vascular compromise also should be taken into consideration. Like any of the audience want to discuss specifically, I can answer to that.
Sir, due to time constraint, we will make it later time. Any questions from the audience? Hello? Sir, any questions? Okay, sir. Inju,
Yes,
very
sir.
nice presentation in a very short period, and treatment part and
Maybe radiology requires more days and more presentations, and not maybe 1 or 2 not sufficient. Posterior can have
not sufficient.
presentation. Rajesh can do one more presentation for us.
Sure, sir.
For treatment part and treatment of the head injuries and hemorrhagic stroke or ischemic stroke can be done later. If there are no questions, we will close the session. Thank you, Shinju. Thank you, Raya sir. Shinju for an excellent presentation. Raya sir for wind up in very fast, a short period. We will make another session in detail about the treatment part, sir. Thank you all for your active participation. Thank you.
Thank you, sir.